So welcome to our webinar series. Vanguard Research Group is hosting a series of webinars with one webinar a month with topics ranging from different areas of research and clinical topics. We had spoken in the past few months about conducting research at community mental health centers and had a couple of webinars on the basics of research called Research 101. In case you are interested and missed those, you can go to our website at vanguardresearchgroup.com. There is a section called Past Webinars, and you can listen to a recording there. Today we'll be talking about the concept of clinical high risk for psychosis. My name is Marta Hauser. I'm the Director of Outreach, Quality Assurance, and Training at the Vanguard Research Group. And before we dive into today's topic, again, for those of you who don't know us that well or haven't worked with us, Vanguard Research Group is a research organization specializing in community health research. Our mission is to connect real-world treatment centers with the opportunity to participate in research. We are pretty selective in what trials we take on because we want those to be in line with the treatment needs of our community health clinics. And we also partner with you all outside of clinical trials. So for example, we just initiated a project in which we assist clinics with their quality improvement projects. So you can reach out to us if you would like some assistance with that, or we provide continuing education like this webinar series. And also just looking back for a second, again, in case you missed the previous webinars, and we'll be talking a little bit about research results in this presentation. So just wanted to point out, although everybody I'm sure has an idea of what research is, just wanted to point out that it's really an organized, systematic activity designed to answer questions. So not just about, for example, new treatments, but also, as we'll be seeing today, about, for example, course of disorders or specific symptoms of disorders. And as opposed to clinical care, the important thing in research is that everything is standardized so that we can make conclusions from the answers that we get from people. They don't necessarily, the standardized questions don't necessarily benefit the patient, but of course the hope is that it will benefit patients in the future. So we'll just keep that in mind as we're going through the presentation. So without further ado, we'll be talking now about the concept of clinical high risk and background history, basically. We'll be talking about symptoms of the clinical high risk for psychosis and assessment scales, and some current research and practice around that area. So in terms of the concept for clinical high risk for psychosis, in this presentation, we'll be using the term psychosis and schizophrenia at different points. So for those of you who maybe are not working with that patient population or are not that familiar with these diagnoses, just for background, so psychosis is really basically a group of symptoms that involves hallucinations and delusions. Psychotic symptoms can occur within different mental disorders, so it can be within schizophrenia, but it could also be within schizoaffective disorder, bipolar disorder, or also depression with psychotic features. But psychotic symptoms can also occur within substance use or other medical conditions. Now, schizophrenia is a much more specific term for a specific disorder that includes psychotic symptoms such as hallucinations and delusions, and we'll be talking about that in a little bit, but it's less broad than the term psychosis. I'm bringing this up because historically, when we look at the concept of clinical high risk for psychosis, it kind of developed from looking at people that had schizophrenia, but as the term says, right, it's a risk for psychosis. which is because we don't have risk factors at the moment that are that specific that we can say that somebody will develop schizophrenia. It could be a different psychotic disorder. So that's why we use the term risk for psychosis. So in terms of the background, descriptions of kind of the beginning stages of schizophrenia go way back. For example, Bleuler, a Swiss psychiatrist, described the prodromal phase in 1911, so a long time ago at this point, in people who developed schizophrenia. Now, the term prodrome is one that is used retrospectively. So basically, if you have someone that developed a certain disorder, then the prodrome would be the beginning stages of that disorder. So it's also defined as symptoms or behaviors related in time to the onset of psychosis in this case, right, or schizophrenia. We're talking about the clinical high risk because we're looking at it prospectively when we think of it at this point. So we don't know if the person for sure will develop a psychotic disorder. So that's why we're talking about a risk versus when we have a person who developed the disorder and we look back, we can talk about the prodrome, so the beginning stages of the disorder. And the retrospective view is important because we're trying to get an accurate description of the prodrome, which can help us identify symptoms that would be risk symptoms for psychosis. Another thing that you might find when you look at literature is the differentiation between an initial prodrome and a relapse prodrome. So the initial prodrome would be right the very beginning before somebody developed the first psychotic break. If you know a little bit about schizophrenia, oftentimes it comes in episodes with relapses. So that's where you could also see a prodrome to a relapse, to a new episode. So we will be talking a little bit about the retrospective assessment of the prodrome and the prospective assessment of risk symptoms. Again, for those of you who are not that familiar with the diagnosis of schizophrenia, just for the background here, as per the DSM, which is a diagnostic and statistical manual that basically is used to diagnose disorders, that has all the criteria for different mental diagnoses. Schizophrenia is defined by two or more of the symptoms you see listed below here, each present for a significant portion of time during at least a 1 month period. So it could be delusions, hallucinations, disorganized thinking and speech, grossly disorganized or catatonic behavior, and negative symptoms. However, one of the symptoms of the two symptoms must be the delusions, hallucinations, or disorganized thinking and speech. Now these symptoms, and I won't go into, it's a busy slide, into all the details, but those symptoms must create a decline in functioning in one or more areas of life, such as work or interpersonal relations, must be continuous for at least 6 months. And other possible diagnoses that include psychotic symptoms, as mentioned before, such as schizoaffective disorder or bipolar disorder, need to be ruled out, as need to be ruled out other physiological effects of a substance or medical condition. Also, you need to keep in mind for the diagnosis if there's a history of autism spectrum disorder or other communication disorder, childhood disorder, to take that into account. And when you make the diagnosis of schizophrenia, there are specifications you can list, for example, for first or multiple episodes or acute phase or remission, etc. So with those symptoms in mind, it's kind of understandable that there is a lot of burden associated with the diagnosis of schizophrenia. As I mentioned, oftentimes there are several episodes that people go through, so it's kind of a chronic disease with considerable morbidity and mortality. Of course, you know, the burden on the person and their family themselves, but also on society in terms of financial direct and indirect costs. The functioning and psychosocial decline oftentimes start very early in the illness, and as you saw also is really a criterion for the illness. We know that the duration of untreated psychosis is correlated with negative outcomes, and that the duration of untreated illness is even longer. So I'll show you a little schematic where you can see those terms kind of in a visual form. So when you look at the development of a psychotic disorder, you have a premorbid phase and then the prodrome or the at-risk phase. So that would be the illness onset, right, where the functional decline also starts. And then eventually that would move into the onset of positive symptoms and real psychotic symptoms where you would diagnose the schizophrenia or whatever other psychotic disorder. And then, as mentioned, treatment is often delayed. So you'll have a period of time where you have the duration of untreated psychosis, right, as you can see here, DUP, until the treatment starts. And then hopefully after a while with treatment, you would come into remission of symptoms. So between the illness onset, there between premorbid and the at-risk phase, where you have the illness onset, and the first treatment, you would have the duration of untreated illness, right? That includes not just the psychotic period, but also the at-risk period. So why we are trying to find risk symptoms for psychosis is, again, because treatment is often delayed, and that is associated with poorer outcomes. There's a lot of research on this, but to just mention a few studies here of association with treatment delay in schizophrenia, you can find a delayed and incomplete remission of symptoms, lower compliance, greater burden for families and high expressed emotions, higher costs of treatment. So, for a lot of reasons, it's important that we try to identify people early and possibly also treat people early to decrease the burden of the disease, or possibly even prevent the onset of psychosis. So here just another kind of visualization of this. As you can see, the functional decline kind of through the progression of the prodromal phase and then the progression of the illness. And on the bottom here also you see in the prodrome, the functioning kind of declines, has a low point with a psychotic episode, and then with recovery and remission, hopefully stabilizes again. So what symptoms do we know currently, and what assessment scales do we have? Again, we're diving a little bit into the history here. So the prodrome, as I mentioned, has been something that people have been talking about for a long time. It's actually been mentioned in the DSM from the start. But in the third revision of the DSM, there's actually a list of prodromal symptoms. So as you can see, those were significant social isolation or withdrawal, impairment in role functioning, peculiar behavior, impairment in personal hygiene and grooming, blunted or inappropriate affect, digressive, vague, over-elaborate or circumstantial speech, or poverty of content of speech, odd beliefs and magical thinking, unusual perceptual experiences, and lack of initiative, interest, or energy. So why these symptoms, make sense for the prodromal phase as it was described for schizophrenia. The problem was that they're not very they lack validity to really describe a risk for psychosis prospectively. So for that reason, they were removed from the DSM-4. But of course, the idea of the prodrome was kept, and more research was done retrospectively to just find more specific prodromal symptoms that can then be used to study prospectively the risk of progression into psychosis in people that show those symptoms. Currently, we have the DSM-5 version. We do not have a diagnosis of, a prodrome or a risk in the DSM-5. However, there is a section 3 that's called Conditions for Further Study, and the Attenuated Psychosis Syndrome, or APS, was included in that section so that it could be studied further. And we'll look at the specific risk criteria that exist, APS being one of them, in a little bit. So in terms of assessment, one instrument that was used for the retrospective assessment of the prodrome was the interview for retrospective assessment of the onset of schizophrenia. That, as you can see, was published in 1992, so a whole while ago. And since then, we have developed some prospective instruments. So one of them is called the Schizophrenia-Proneness Instrument for adults or for children and youth, so the SPIA or SPICY. And we'll talk about that a little bit more. It's used in Europe a lot, and it's based on the idea of basic symptoms. And those are symptoms that are basically cognitive disturbances and not psychotic symptoms in terms of hallucinations and delusions. The next two scales you see here, the Structured Interview for Prodromal Symptoms and Scale for Prodromal Symptoms, SIP-SOPS, is a scale that is used in the US a lot, so we'll look at that in a little bit more detail. That is a scale that looks at the APS criteria, at psychotic symptoms, excuse me, and so is the Comprehensive Assessment of At-Risk Mental States, the CARMS, that was developed by McGorry in Australia, and is looking at the same kind of symptoms, and is widely used in Australia, with McGorry being a pioneer kind of in that area. So here you see which risk criteria we currently look at and assess for validity. And you see on top that there is a differentiation between an early initial prodrome and a late initial prodrome. So that really refers to kind of the timing, right? So if you imagine the schematic that we looked at, the early initial prodrome would be closer to the premorbid kind of end, and the late initial prodrome would be closer to the psychosis and within the at-risk mental state. The early initial prodrome includes basic symptoms that I just mentioned. So we won't look into the details of the assessment here. There is a lot of details in terms of frequency, intensity, etc., to rate those symptoms. But just so you know, basic symptoms are cognitive disturbances that are thought to be a very early indicator of the risk for psychosis. So is the genetic risk for schizophrenia or psychosis with a functional decline. So this could be either a family relative with schizophrenia or the person themselves having a schizotypal personality disorder plus a functional decline. The basic symptoms are only assessed with the Schizophrenia-Proneness inventory. The genetic risk criteria are assessed by all instruments. And then within the late initial prodrome, you have the attenuated psychotic symptoms, the APS symptoms, which are basically psychotic symptoms that are not as severe yet. And so there's basically, a person would basically experience some sort of hallucinations or delusions, but would have some doubt about their validity. So that's one possible set of criteria. The other one that you see here are brief, limited, intermittent psychotic symptoms, blips or bips. And those are full psychotic symptoms, but they're transient and they resolve on their own and are short-lived. And those two sets of symptoms are assessed with the SIP-SOPS that we just spoke about. and CARMS, but not with the Schizophrenia-Proneness Instrument. So for the Schizophrenia-Proneness Instrument, what's important kind of to know is that those basic symptoms are thought of as subtle symptoms and self-experienced symptoms. So looking at a person, you wouldn't necessarily, see them basically, right? So they need to report those symptoms and disturbances that could be within their drive or stress tolerance, their affect, thinking, speech, perception, motor action. We'll look at some, excuse me, at some examples in a little bit. And these are different from psychotic symptoms, as mentioned. They are called basic also because they are thought to be present as a very basic underlying disturbance that can be present before the first episode, between episodes, after, and even during episodes themselves. There is a differentiation that is kind of subtle between cognitive disturbances called cognitive or cognitive perceptual basic symptoms, the COPA criteria. We'll look at that also. The assessment takes about an hour, and the SPI-C, the scale for children and youth, can be used from the age of 8 years on, although some of those symptoms are kind of elaborate higher cognitive functions. So some of the symptoms are assessed from the age of 13 years on or include apparent caregiver information. So if you look at this chart, you see which symptoms are thought to be part of which set of criteria. A lot of them overlap, as you can see. And just to give you an idea, again, these are very subtle symptoms that are self-experienced. So for example, thought interference would be the experience that your train of thought is interrupted by irrelevant thoughts that kind of just cut in. It could be just a word or, a thought, and, something that maybe we all in a way experience, but that is experienced by the person as somehow new and puzzling. And again, there's, there are very detailed anchors in terms of frequency and impairment, etc., resulting from it. But that's the general idea of that symptom, for example. Thought blockages would be a sudden loss of your train of thought. And again, it happens to everyone, but it would be experienced as something strange or unusual or just happen more often and lead to some sort of impairment in functioning. There could be disturbances of receptive or expressive speech. So words that are kind of simple, all of a sudden you're not sure what they mean anymore, or you have difficulty expressing yourself and finding the right words. There could be something like captivation of attention by details of the visual field. So something in your visual field just almost feels like you're magically drawn to some detail that's really not important within your visual field. So these kind of things are considered basic symptoms and are assessed with that scale. In terms of the SIP-SOPs, it's a structured interview for more psychotic symptoms, as mentioned. So it includes different items that we'll look at on the next slide, but includes, of course, positive symptoms, negative symptoms also, and disorganized symptoms, as well as general symptoms. And again, there's a very detailed anchor to the 7-point scale in terms of frequency, severity, how much a person believes that those symptoms are real or those experiences are real, and things like that. Within the rating, a rating of 3 typically points to a severity that is considered significant for the risk for psychosis, and a rating of 6 would be considered severe and psychotic. And that scale also takes about an hour to administer. So here you have some of the symptoms that are assessed. And again, if you look at the positive symptoms and think of the criteria of attenuated positive symptoms, these would be things like you feel like somebody might be watching you, but at the same time, you kind of think it's not really true, it's not really reasonable to think that, so there's some doubt. If you had brief intermittent psychotic symptoms, you would be convinced that somebody is watching you, but it would be the severity of psychosis really, but it would be a transient, short-lived symptom. So these are the ways we have been assessing symptoms for risk of psychosis. Now we'll look a little bit into the current research and practice. The idea, of course, for assessing those symptoms is to predict who will be transitioning to really developing psychosis. So we've been looking at this prospectively for 25 plus years, so for a while, and early transition rates were pretty high, but we don't find those high transition rates currently. So one of the very first prospective studies that was done on basic symptoms in 2001, just to give you an idea, looked at 385 subjects and followed them for 9.6 years, so for a pretty long period of time. We had about half the subjects, 160 subjects at that time, to evaluate, and the study found a 70% transition rate. In terms of the other criteria, the psychotic symptoms that are assessed with the SIP-SOPs and the CARBs, early transition rates showed transitions of 40 to 60% within a 1 or 2 year period. So those were results that seems like it's possible to identify people at risk for psychosis. But again, numbers declined a little bit for different reasons. And when we looked at or conducted a review of the literature a while back now, we included 35 studies and more than 2,500 patients. You can see the age is about 20 years, about half are male, and the studies included all of the risk categories that we just spoke about. It's important to mention that, however, subjects were also receiving treatment, naturalistic treatment, and you can see here that ranged from antidepressants and antipsychotics to psychotherapy. So there is some sort of treatment involved. And the results of the studies that we looked at ranged from 0% transition to the 70% that we saw in the early basic symptom study. Follow-up period was between 2 months and almost 10 years. So when we weighted all these characteristics of the studies, we came up with a pool-weighted follow-up of 23%, 23.2% after 2 years, basically, of transition to psychosis. So that number is fairly low, right? If you wanted to identify someone and treat someone for psychosis, for the risk of psychosis, then the chance to actually develop psychosis wouldn't be necessarily that high with those transition rates. So for that reason, we need to do more research to reduce false positive rates and kind of find really what a meaningful risk, what that really means, right? So the idea is to look at underlying other clinical factors or biomarkers, which has been done. So again, these will be pretty busy slides. And I won't go through all the details, but just to give you an impression of the things that have been studied. For example, in terms of clinical risk factors, as you can see, the longer the follow-up period is, right, you see the transition rates rising. So of course, the longer you follow people, the higher the chance that they will actually transition to psychosis. You see there's different numbers for basic symptoms and for CHR stands for clinical high risk, UHR is ultra high risk. So both sets of criteria are in this table, and you can see again that the numbers are rising with time. Basic symptoms are basically kind of the earliest clinical indicators within the clinical high risk approach. People that had brief transient psychotic symptoms were more likely to convert with 48% than people with attenuated psychotic symptoms at 25%. And in this study, really in this review, the genetic risk with decline in functioning really didn't show much of a transition at all. In terms of other clinical risk factors, you see, we're going to post this on our website, so if you want to look into the specific studies or details, you're welcome to, but just to mention, in general, what has been studied is premorbid adjustment of functional decline as a risk factor or additional risk factor. So is the severity of risk symptoms. Cannabis use has been studied as a further additional risk factor to see if that would help predict better who will actually transition to psychosis. Obstetric complications, microbial infections such as T. gondii infections, and depression. In terms of biological risk factors, people looked at the EEG of patients with that show clinical risk symptoms for psychosis. So you can see different aspects of the EEG studies here. There's just a bunch of different findings for event-related potential, for sensory motor gating. There's also, I don't have a table for this in here, but a lot of research being done in functional imaging and fMRI. All of this is, adding to our understanding, but we have not found really specific other biological or clinical risk factors that enhance the predictability enough to be included as a diagnosis, for example, in the DSM-5. So there's different models that looked at combining different risk factors, and of course, if you do that, you will get a bit of a better sense of who will develop psychosis. At least statistically, you get better transition rates. But there's still more research to be done to really understand who will actually develop psychosis of the people that show the risk symptoms that we've discussed. So for that reason, Vanguard, for example, is a part of one of those studies. This is a big international study that we call ProNet. That is part of the Psychosis Risk Outcome Network. As you can see, there will be just over 1,000 subjects assessed at 26 sites, international sites, as well as healthy controls. So the subjects with clinical high risk for psychosis will be scored on one of those assessment scales to make sure that they display the risk symptoms we just spoke about, as opposed to the healthy controls. They will not receive treatment, but will be assessed on different measures with clinical interviews, patient-reported outcomes, MRI, EEG, labs, neuropsychological testing, which is also a big part of potential additional risk factors, which cognitive disturbances or limitations there are, and which ones are specific possibly for clinical high risk. So people will be assessed with those different assessments for 2 years and followed for 2 years to then hopefully find some measures that will inform individual trajectories within risk subjects. with the idea, of course, to possibly also inform treatment. So again, the idea is, right, for identifying people to possibly also being able to intervene early and possibly delay the onset of psychosis or even prevent the onset of psychosis. However, the recent review shows there's not enough evidence at the moment to favor any particular intervention. There have been studies completed looking at different interventions. So, for example, low doses of atypical antipsychotic medication, cognitive behavioral strategies, and omega-3 fatty acids. And again, early studies showed that there might be a possibility of delaying or preventing the onset of psychosis. So, for example, one early study done by McGorry's group in Australia looked at risperidone plus CBT and found that after 6 months, there was a difference in the transition rates in the experimental group that showed 10% transitions versus the control group that had 36% of transitions. Another study by Morrison's group that included cognitive behavioral therapy for 6 months also showed a difference in transition rates after 12 months. So there is some hopeful results and some indication that cognition might be improved, functioning might be improved, symptoms, of course, and possibly psychosis might be delayed. But again, we just don't have enough information at this point to really favor a specific intervention. And so that's why we, at Vanguard are very interested also in participating in research that could help people by just identifying risk factors more specifically, and then hopefully from there being able to identify interventions that might help people at risk for psychosis. So I hope that gave you a little bit of an overview of the clinical risk for psychosis and where we stand with that today. You're welcome to check out our previous webinars or to go back to a recording of this webinar at vanguardresearchgroup.com to look back at the details of some of the slides if you're interested in the specific research outcomes. Also feel free to contact me or contact us. You'll find our contact information on our website. You can also follow us on LinkedIn, Twitter, Facebook. We're also on TikTok. So happy to get in touch and tell you more about this study that we're part of at the moment or any other future studies if you're interested in participating in research.